quick summary of benzodiazepines. These are drugs in the class benzodiazepines used for calming down our nervous system. It slows down your brain activity, targeting GABA receptors. Here we are going to discuss 5 to 6 drugs, most commonly used ones in this section, and distinguish different indications. What are the specific, at least one indication I wanted to distinguish for all these drugs, and why it is unique for that specific function or indication. Okay, so let's start with the first drugs. First two drugs in this list, Triazolam, Midazolam, those two drugs are short acting benzos. Triazolam is good for as a hypnotics, so indicated for chronic insomnia, not for long-term prescription. I'm going to tell you the reason in few minutes. For long-term prescription sleep aid drugs, we consider non-benzos. These are Z drugs. We will discuss that. So triazolam short acting benzos, but short-term prescription, 7 to 10 days prescription. We can use it for jet lag, maybe one-time prescription. One time you can take it, or for chronic insomnia. Okay, good. Severe insomnia condition. Second drug, midazolam. Here, this drug is very effective for preoperative sedation. Reason is this drug passes the blood-brain barrier very quick because of its unique structure and bind on the hippocampus. GABA arranged in that specific area. Therefore, after that, you will forget using this drug. You will forget certain that specific incident. So, therefore, midazolam is specifically using for that purpose. Okay. Then the next two drugs are intermediate acting drugs, Alprazolam and Lorazepam. Of course, those have also unique indication. Alprazolam, we use it indicated, FDA indicated for panic attack, right? Panic disorder, usually acute panic attacks. Reason, this unique structure can easily attach or bind on the GABA receptors of your amygdala. AA, that's how I remember. In amygdala, that is why amygdala related fear or panic attack, it will be effective. It has a unique structure we will discuss. That is why it can pass blood-brain barrier very quick and effectively, very effective. But there is a difference. Alprazolam, it can be used for quick, like if it is panic now, if you have to use it, you can use alprazolam. But panic attack every day, you don't use alprazolam, but you can use clonazepam. That drug is for panic attack every day. I'm going to distinguish the function later, why it is so. The next two drugs, the Lorazepam and Alprazolam, I was talking about intermediately acting. So Lorazepam, I wanted to study two indication. Both are super important. First indication is status epilepticus. We can use it for status epilepticus, and also alcohol related called seizures and all, right? Alcohol withdrawal symptom, that will be very effective. So you may be asking, what about diazepam, right? There is a specific reason diazepam is not the go-to drug for alcohol withdrawal symptom. Okay. Then one more point, I am going to connect with some other drugs, because if there is a Lorazepam when we study for alcohol, you may think about smoking cessation, right? Smoking cessation, we don't use these drugs. We are going to discuss another drug called Bupropion. That's an entirely different drug. We're going to use it for smoking cessation, and I'm going to discuss what is the purpose of that and mechanism. Okay, so anyway, stop right there. So Lorazepam for alcohol withdrawal symptoms, very good. Then the next drugs, Diazepam And the clonazepam and some drugs like chlordiazepam, all those drugs are very long half-life. For instance, in diazepam, if I talk about, this has like a multiple of intermediate metabolites. All those have longer half-life, like methyl diazepam, temazepam, oxazepam, all those have longer half-life. That's why they stay in the body for longer time. But still, this is not the go-to drug for certain conditions like alcohol withdrawal symptom or seizure control, long-term control. The reason is diazepam has a unique structure which pass blood-brain barrier very quick. Similarly, it will rush in and rush out. From the brain, it will get out very fast. So CNS, maintaining CNS concentration will be lower compared to lorazepam. I'm going to discuss in details in few seconds. So keep in mind, diazepam therefore is best for acute seizure control. One more point, one more time. Diazepam, the difference from lorazepam is because of its unique structure, diazepam is good for acute. Reason, because of its structure, diazepam can pass blood-brain barrier quicker than or faster than lorazepam. So therefore, it is very good for acute seizure control. Good. One more point, it get into the brain very quick, do the duty and get out, right? So when it get out, because it is having longer half-life, this can hang in the body for a long time. Especially it can penetrate into the skeletal muscles. It pass the skeletal muscle tissues and distribute. Therefore, this is very good for good as muscle relaxant also. Okay, that's a unique function, unique indication. Then yeah, let's stop right there and talk about why benzodiazepine and what is the difference between benzo and non-benzo. Okay, this is it. All the benzodiazepines and non-benzodiazepines, why do they call together in one group? Reason, these group of drugs bind on GABA receptors of our brain. That's it. Benzodiazepines are entirely different class. Their structure is unique, I'm going to discuss. But non-benzos, they doesn't have any structural similarity with the benzodiazepines. But all these group drugs, these all are going to bind on the GABA receptors to calm down our nervous system. That's it. So how do they work? Easy to understand. They will work in presence of GABA. So think about, you are going for a dinner. 3 people are going to dinner. That's how I remember. 2 VIP in a VIP lounge, 2 VIPs are GABA. 2 GABA has to bind on the GABA receptors, then only the chloride channel open. It will undergo hyperpolarization and therefore our brain CNS depression will be the result. Good. So benzodiazepine, think about this person came to the dinner table early. It take the seat and move the chair a little bit aside so that GABA can bind well. So it moved the chair. That's how I remember. So keep in mind, benzodiazepines and even non-benzos can positively modify the structure of the GABA receptor. That means positive allosteric modulator, so that GABA binding will be facilitated. That's a super important point. So that chloride channel will be continuously opening and closing. So open, close. Similar effect. It will cause a lot of chloride ions to rush in. Very good. Function, different functions like a hypnotic function, like a sleep aid, anxiolytic function, calming down your nervous brain, anticonvulsant, seizure control, everything. Okay, we will discuss why, everything. But stop right there. But the problem with this benzodiazepine, if you do overdose, if you give a lot, after the dinner, the benzodiazepine will not leave because there is a lot, right? So benzodiazepine taking stuck in that seat. Okay, that's not good. So that's where we use a rescue agent called Flumazenil. right here, Flumazenil, that is a rescue agent. This drug, it's like it's a unique drug. It will not affect the GABA binding. This is like a VIP club uh, with a bouncer or a security, right? When flumazenil comes in, flumazenil will kick the benzodiazepine out. Benzodiazepine took over the chair, remember? It's not leaving. But flumazenil has the power to, because flumazenil has more affinity to benzo binding site. So it will take over the chair, it block the chair so that benzodiazepine has to leave. Okay, very good. This flumazenil know how to respect the privacy of GABA so that it will not affect any GABA binding or anything, stay where they are. But one problem here is flumazenil has very short half-life. It's like all these securities and bouncers have minimum, especially the time, right? Schedule. After the schedule, they have to leave and come another person. Similarly, all the benzodiazepines have longer half-life than flumazenil. Therefore, if you during overdose, if you get too much benzodiazepine in your blood, it will stay in the brain, so that once the flumazenil's half-life is done, after an hour or 2 hours, you pee it out, it will be gone. That time the benzodiazepine come back to the seat. That is the reason you end up in sedating again, the person to get into coma. Therefore, after a couple of hours, you need to give more flumazenil. But keep in mind another point to remember here: if a patient has seizure, you should never give flumazenil. Reason: remember, seizure has to be controlled, calmed down by activating the GABA receptors. GABA receptor has to slow down all these glutamatergic channels. Therefore, you need more chloride channel to flow. If you already block the with a flumazenil, it's going to cause more seizure and the patient can die with coma and other problems. So that complications. That is the reason. That's also a contraindication of flumazenil. Anyway, remember, flumazenil can be useful for both benzodiazepine or non-benzodiazepine overdose. Why? If anybody asks, this is it. All these 5, 6, 7, 8, 9 drugs bind on and works on the GABA channel, GABA receptors, and the flumazenil can block their binding site. That's it. Very cool. So we understood that. So now let's look at the drug one by one and distinguish why. For instance, somebody asks you, why don't you use, if somebody has like a stage fright, why don't you use any benzodiazepine? For instance, somebody has to do a presentation, right? So performance anxiety, you don't prescribe benzodiazepine. What is the reason? Very easy to understand. Look at right here. Propranolol is the go-to drug for that. The reason is propranolol will not affect direct or inhibition of GABA receptors. Nothing to do with that. Reason: our stage fright and performance anxiety is related to cardiovascular outcome, like a cardiovascular effect of anxiety. For instance, like palpitation, sweating, tachycardia, all those. Also, when a person is on stage, we don't want to suppress their brain activity. Of course not. Then they will forget everything, isn't it? So therefore, we need to keep the brain function normal. That is the reason. We go for propranolol. Mechanism of action is different. You know that beta-adrenergic receptor antagonism, right? That's an entirely different story. I want you to connect that with this benzodiazepine story. Why we don't use it for that specific, okay? Okay, very good. So let's look at this structure and then we will go to the function of the non-benzos, okay, for sleep prescription. Okay, so why is it called benzodiazepine? Easy, anybody can answer. Because these are structures with a benzene and a diazepine ring. That's it. Different, all those five drugs have different like additional units. For instance, diazepam, I told you, with a longer half-life. Why? It has a lot of additional structures. For instance, molecules. For instance, it has a methyl group, so that it affects the metabolism, and some of the metabolites are very long acting, very good. It has chloride, like halogenated subunit attachment, right? So this will increase the lipophilicity. Therefore, diazepam is more or easy for lipophilicity is so high, so it can pass the blood-brain barrier very quick, fast. Remember, I was talking about it is for acute seizure control, very effective. Reason because of this halogenated structure. You don't have to memorize the structure, but understand what is the difference. When you look at the Lorazepam, of course they have a halogenated, but the structural difference is still there. Okay. And another point to remember, see, there is no structural methylated group. That means Lorazepam does not have active metabolites. Then if you look at Alprazolam and Triazolam, why do they name that? Because they have triazole structures attached to that. That is the reason. Triazolam. But how do I remember? Just one point to remember. They just took up alprazolam and added a halogenated group, chloride. That's how they created triazolam. In triazolam, you can see an additional chloride group right here, right? So that's a difference. So that will make triazolam more lipophilic than alprazolam. Okay. And then these if you talk about alprazolam and lorazepam were intermediate acting benzodiazepine, and one more drug with a shorter half-life like triazolam was midazolam. What is the difference of midazolam? Easy. It has, in addition to that halogenated group, they replaced with a fluorine. The chloride is replaced with the fluorine. Therefore, this can pass the blood-brain barrier faster than triazolam. Okay, so that's all. Just, you don't have to memorize, just understand. This is the reason we get a different function for these drugs. Okay, because of its structure. So let's go through one by one. Okay, so now you know, because they have benzene and diazepam rings, they are called benzodiazepine. But because the non-benzos, of course, they are also binding on the GABA receptors, but they do not have benzene and diazepam ring, but instead they have like a pyrazolopyrimidine, imidazopyridine, and cyclopyridine. You don't have to memorize. So different structure. That's all you need to remember. What you have to remember from these three drugs? One of the drugs with a very short half-life. Therefore, it will be gone from the system very quick. That is very fast acting also. Therefore, it can be indicated for sleep onset insomnia. Just easy to fall asleep. Work within 15 minutes. But the second drug, it will take up to 30 minutes to work. Of course, you can use it for onset insomnia. Oh, and maintenance, because it has a longer half-life, it will keep you asleep for longer time. So this is used for both sleep onset and sleep maintenance insomnia. Then the third drug, that is the real indication by the FDA, because esopiclone, I capitalize those letters because that's how you pronounce esopiclone. That's it. So it starts with the ESZ. Okay, that's a spelling. Anyway, that is a Z drug because it has a C right here. See, these are C drugs. So esopiclone has a longer half-life, but it has a binding affinity that is actually a non-specific binding affinity, but still it works well. Less adverse effects like a sleep parasomnias, like sleepwalking, sleep driving, all those less frequent than the other two drugs. Therefore, this is indicated for long-term sleep prescription. So if long-term insomnia, if a patient has to take, this is a comparatively good drug. Okay, so what are the three things to distinguish? Zaleplon, usually prescribed for shift workers, and also doesn't have hangover. The reason, it has shorter half-life. Even a person like a, maybe they watch something TV or something until 2 in the morning or 1 in the morning, they can take late night. Reason, it will be removed from the system very fast because it has about an hour of half-life, and it will be removed, but less rebound, or they have very lesser hangover, very low hangover at the morning. That is a unique feature of this drug. Okay, even in market we have a sublingual form of Zaloplan. Some patients, if they wake up in the middle of the night, they can take that as a sublingual middle of the night. If they can take it, they can keep sleeping after a couple of hours. Make sure they have 3 to 4 hours more. Okay, anyway, so Zolpidem, the next drug, this drug has a longer half-life, but I want you to remember one thing. In females, this drug has to be lower dose, usually half dose than male. That's an important point, okay? Why Zolpidem? That is the most commonly prescribed sleep drug for in United States currently, because it is very effective. But Zolpidem actually having in the females, the reason is because of their hormonal condition. Hormone has effect, and metabolism will be different, and also it can redistribute into the fat. Of course, if you are asking, all the three drugs can redistribute into the fat. Salplan can have more redistribution in fat, but Salplan removed from the system very fast. Therefore, Zolpidem is the drug which will have like a lesser effect in female. Therefore, sorry, it has a higher effect in female. That is the reason you give like a half a dose or reduced dose. That's one point to remember. And the last one, Esopilicon, I already discussed that. Only drug FDA indicated for long term, like strictly. Of course, Zolpidem also indicated, but it has a restriction, like a with caution. That's what it says. But Esoplicon, Piclone, only a drug for long term use for insomnia. Okay, then if you have to remember in one way, one like a quick point, I remember this way. This is like a sleep coach. Piclone is like drinking espresso clone, right? This will be lasting longer but leave bitter taste. At morning, you still have that sleepiness, sedation, a lot of sedation. So that's the difference between that other drugs. But if you compare with the next drug, more sedation, because it is a Triazolam drug, that is a benzodiazepine. But keep in mind, this will be like a sleep coach. So if you compare again with the Salplon will help you to, it's like a tucking you into the bed, tucks you in, right? Only tucks you in Salplon. But the next two drugs, Zolpidem and Esopicons, stay with you throughout the night. I wanted to compare those drugs with no residual effect. Those are two drugs in the bottom. Ramelteon and Suvorexant, these are nothing to be related to benzodiazepine or non-benzos, but these are sleep aids or hypnotics. That's why I wanted to study together, okay, with this group. Keep in mind, Ramelteon, entirely different function. This is a MEL, melatonin receptor, MT1 and MT2, two melatonin receptor agonists. So this will make you fall asleep. This is also similar to Salplon, shorter half-life. It will be very effective to fall asleep. Okay, for shift workers, this is good. You will fall asleep. It's like effect of melatonin. But compared to that, another drug, Suvorexant is an orexin receptor antagonist, entirely different neurotransmitter. So to suppress or the maintaining the drug which maintain wakefulness, the neurotransmitter which is maintaining wakefulness is orexin. So orexin is actually, see, orexin, there is an O here, okay. So orexin regulating or antagonizing drug that will help you to fall asleep. So orexin, okay. So remember the mechanism of action, OX1, OX2 antagonism. Fair enough. But here that has a long half-life drug, very good drug, and these two drugs are without any addiction or withdrawal symptom so far reported like that. Reason, these drugs have nothing to do with this GABA receptors. We were talking about, of course, all these drugs pass blood-brain barrier, but it will not bind on directly to the GABA receptors. That is the reason. It is a different mechanisms. It will control or help for sleep. Okay, so now let's move to the typical benzodiazepine. So triazolam, what is the major things to remember? All these drugs has affinity to alpha 1 and alpha 2 subtypes of GABA. Okay, so now you know the basics. I want you to remember all the GABA in our brain will not look alike. Of course, typically GABA has 2 alpha, 2 beta and 1 gamma subunit. But all these subunits have additional subtypes. For instance, it's like identical twins. They don't look alike. There will be difference. Similarly, in my brain, my neurons, GABA receptors look differently. Some of the GABA receptors alpha unit were alpha 1 subunit, or some of them has alpha 2, alpha 3 or alpha 5. Remember those 4. That's super important to distinguish these 5 benzodiazepine. That's it. We are almost done. So keep in mind, all the benzodiazepine and non-benzodiazepine can bind on alpha 1 receptors. GABA receptors, GABAA receptors, alpha 1 binding site. Therefore, all of these drugs have the effect of hypnotic and sedation. One more point, one more time. All the benzodiazepine and non-benzos can treat your insomnia or make you fall asleep, and also it can make you sedated. Reason, it has an affinity to the alpha 1. Very good. But in your brain, most common alpha subtype is alpha 2. But it has more affinity to all the benzodiazepine. That is the reason benzodiazepine can be anxiolytics. Okay, all these are very fast acting anxiolytics because it is affecting GABA directly. Okay, so let's talk about that. Midazolam. In midazolam, the difference is midazolam has an affinity to alpha 5 subtype. Alpha 5 subtype, that means alpha 5 containing GABA is present a lot in my hippocampus and some of the limbic system parts. This is useful for my memory. That is the reason when we use midazolam, people can forget that incident, right? So this is why this is good for preoperative procedures. Okay, keep in mind, midazolam has affinity in addition to alpha 1, alpha 2. It has an affinity to alpha 5 that is more other than other drugs because of its unique structure. That's it. Therefore, you get anterograde amnesia. Very good. It's like a ninja for memory eraser. That's how I remember midazolam memory eraser. Fast in, fast out, leave no trace. IV and IM can be used for CNS. Duration is very short, redistribution is high, all those points. Just remember at least this point. Okay, different indication, reason, different affinity. Very good. Fair enough. Next, move on. First 2 done. First 4 Uh, in what is it? Triazolam we indicated for chronic insomnia. We can give it for jet lag. But the problem is because of this GABA affinity, it has a lot of a rebound insomnia and withdrawal symptom. That is the reason restricted to short-term prescription. Okay, that's a very important thing to remember. Another point maybe to remember, it's like an emergency parachute for sleep. Triazolam is an emergency parachute. You don't use it for every day, right? It's for emergency. It's like fast and furious. It has all these adverse. It will work very well fast, but it has a rebound insomnia, withdrawal symptom, all those. That is the reason you used as an emergency parachute for sleep or insomnia. But the other drugs, salplone, solpidem, esoplicone, all those, we can use it for as a sleep coach or something like that. Does that make sense? Okay. And then Alprazolam, the next drug. Alprazolam and Lorazepam, we were discussing about it has a longer half-life. Let's talk about Alprazolam. Alprazolam has an affinity to the GABA receptors with a alpha 3. Okay, there are multiple alpha 3s, but just remember, because of its unique structure, very huge structure, it has a specific access to our amygdala of our limbic system. Therefore, alprazolam is very effective for amygdala related fear and panic disorders. So it work like a panic sniper. Panic now it will work like pass blood barrier very quick, and half-life is about 10 hours and it work really well. So you can use it for panic attack. Alprazolam, reason alpha 3 specific GABA receptors of the GABAA receptors of amygdala. Same function, all the detailed mechanism, same thing. The next drug, Lorazepam, why is it different than the previous drugs? Reason, here because of its unique structure, they bind to a specific alpha 3 receptors. Because of its structure, this will go to the alpha 3 accumulated in our thalamus of the brain. Both diazepam and lorazepam, keep in mind, lorazepam will not have any, because of its structural difference from diazepam, lorazepam does not have. Alprazolam, lorazepam does not have any long active metabolite at all. That's why they both are called intermediately acting benzodiazepine. Anyway, lorazepam going to be binding to alpha 3. Similarly, diazepam also can bind into alpha 3. But why do we use lorazepam and or diazepam as anti-seizure drugs? When I taught you anti-seizure drugs 2-hour lecture, we learned these two drugs. Why? This is the reason. These have an affinity to alpha 3 receptors accumulated in the thalamus region, limbic, all those areas. That's why it can calm down, it can reduce anxiety, it can, so it has an affinity to that alpha 3 receptors. Mainly it can get into thalamus. Thalamus is the gateway to your cerebrum. Therefore, it will be effective for generalized seizures. Very good, understood. So if anybody asks you lorazepam specific function, we were talking about half-life is about 20 hours, and diazepam, because of the additional, I was talking about the metabolites, right? Active metabolite like desmethyl, diazepam, temazepam, oxazepam, those metabolite is staying in the body for a long time, especially in the fat distribution in tissues, in the muscle, all those, so that it will be longer half-life. But what is the difference? Diazepam has, because of its halogenated specific unique structure, they can get into the brain faster than lorazepam. Therefore, we use diazepam for acute seizure. Lorazepam, we can use it for alcohol withdrawal symptom. Compared to diazepam, we can trust Lorazepam more. Reason, Lorazepam get into the brain very quick and it can get out that speed. Of course, it can stay in the brain for longer time after complete tissue distribution, but it will go in fast, but it will get out and stay in the tissues a lot, like especially in the fat and muscles a lot. Therefore, if you have a choice for alcohol, you don't want to give after 3 4 hours. You don't need to give again, right? If they have seizure, you need to go ahead and give again. So therefore, lorazepam up to 12 hours you can control a seizure. So therefore, lorazepam for alcohol withdrawal symptom, and also it will be for a maintaining the seizure in status epilepticus. Okay, stop right there. Lorazepam and diazepam can be effective for status epilepticus. Of course, especially diazepam, it quickly get into the blood. It will be good. But we stick with this lorazepam if you have a choice because it will stay in the brain for longer time. But these are, it's like a quick, like a direct control of seizure, directly targeting GABA. You have to think about another point. You need a sodium channel blocker for prevent seizure propagation. That is the reason after using to control shut down seizure, you can use another drug called, that is an anti-seizure drug named Forsphenytoin. Remember, that is a pro-drug of phenytoin. That's it. IV, you can use it. So Forsphenytoin, longer half-life, and it stay, maintain, and block the sodium channels in the patient's brain. Therefore, it will prevent the propagation of seizure. That's the difference. After this, you are adding the maintenance dose for long-term control of seizure. Hope you understood that point. Okay, let's go back. Then the diazepam story. Okay, like I told you already, diazepam can rush in fast and rush out fast. Therefore, acute seizure, you can use it. Muscle relaxant, you can use it too. Okay. Or did I miss any point? Okay, so I bold this one because you have to remember, you see that question for a long time, like everybody asked. Also in emergency department, you're going to use that. Lorazepam and diazepam, why? Anticonvulsant effect, and what is the difference between this Forsphenytoin? Because entirely different. This targeting GABA receptor, Forsphenytoin is controlling the or shutting down the propagation of seizure by blocking sodium channel. Okay, good, fair enough. Then what did I miss? Clonazepam, I already explained to you. Clonazepam is for, remember, panic attack. Alprazolam is panic now, and clonazepam is panic every day. So what did that mean? Because it has a nitrogen at a C7 site, it has a high potency, longer duration, it can stay longer. Even we can use it for chronic anxiety, epilepsy, potent anticonvulsant, epilepsy in children, a lot of different function. So it has a smooth plasma level, no peak and trough, and a longer half-life, about 40 hours. Slow onset, that's why I didn't make it as bold. The first 5 drugs are benzodiazepine with a quick fast action. Clonazepam function only, like at least 2 hours later only it function, but it, remember, it has a sustained or prolonged action. Therefore, it is used for panic attack, for long-term prescription, FDA indicated. Okay, so we are done with the, we are not done, don't leave benzodiazepine this part, but I wanted to compare that with a couple of, for instance, a most commonly asked board question, what is the difference between benzodiazepine and barbiturate? Look at it. Or alcohol, ethanol. What if a person take benzodiazepine and drink alcohol? Maybe they forgot, they drink some wine. What will happen? So, or even the non-benzos, any of these drugs which binds on GABA receptors, and if they are adding any other GABA uh, uh, agonists or stimulating drugs, you're going to get into coma and death, right? So what is the reason? Okay, let's look at barbiturate first. You can see right here, I put it at the bottom. GABAA receptors, beta subunit, don't worry about the beta numbering, it is too much for you, just study up to there. Because barbiturates has an affinity, that's a different class of drug, right? Phenobarbital, all those drugs. This has an affinity to beta subunit of the GABA. Therefore, this has an anesthetic action. If somebody asks you why benzodiazepine doesn't have an anesthetic action, this is it. Because benzo binding site on the GABA is at the alpha gamma interface. Also, Z drug also has an entirely different chair seat at the alpha gamma interface. That has nothing to do with the beta. Therefore, there is no anesthetic action. Okay, good. This barbiturate bind on the beta, that's why it has enough anesthetic action. What will happen if you add ethanol to it? So we look at it. Ethanol, alcohol, will go and bind on our GABA alpha subunit. Therefore, it will increase. That means it undergoes sedation. If you drink alcohol, you feel like sedated for hours because it will keep your chloride channel open and closed continuously. But I want you to remember what is the difference between all these drugs from barbiturate. Why that is a very, like remember anesthesia, people can die. So why is that? We're going to discuss. Did I miss anything from this page? Flumazenil we discussed, Forsphenytoin we discussed. Keep in mind Flumazenil, rescue agent for any of this benzodiazepine overdose, not for barbiturate overdose. Reason, Flumazenil is because of its binding affinity and all, right? This drug is not the rescue agent for barbiturate. That's another reason. Barbiturate does not have any rescue agent. That's also a unique point. But for the class exam, I want you to focus on this area, okay? Also for the clinic, you will use a lot of these drugs and Flumazenil. Okay. Forsphenytoin we discussed, that is for the long-term control of more than 30 minutes if it lasting. You can use it for maintaining the brain function in seizure, right? That is an anti-seizure drug class we discussed. Propranolol we discussed. That is for you need to keep the brain function, nothing to do with this direct function of GABA, but it is a cardiovascular effect of anxiety. That is the reason for tachycardia, sweating, when you are worried to present something, and you can take this and control that functions. Okay, so Ramelteon we discussed, Suvarex, and those last two drugs are the hypnotics or sleep aid drugs. Okay, the next two drugs, Bupropion and Buspiron. Okay, most commonly asked drugs. These two are like, I want it because it looks alike. I used to like confuse with these drugs always. I want you to remember that very specifically. Bupropion, this drug is considered as an antidepressant. Just remember one indication each. Bupropion, antidepressant, right? But here the buspirone for generalized anxiety disorder. Okay, I'm going to teach you very well, very easy to understand. I remember this way. Buspirone, general, it's like getting a bus. Generally, everybody sit in the bus. It's not like a private car, right? No speeding, no ticket, nothing, no panic attack, no withdrawal symptom, nothing. Generalized, you buy the ticket, you relax and sleep. It's like generalized anxiety drug, Buspiron. But it is a slow acting. It's like your bus. You have to go early in the bus stop, sit into the bus for a long time to start, right? Similarly, Buspiron work only, it's like compared to driving in the car. Very slow acting. I'm going to show you in another slide. I have a picture. Okay, why? Okay, let's talk about Buspiron. Okay, sorry, Bupropion. I want you to study one point. That's it. Why Bupropion is good for smoking cessation? That's a good point to remember. Reason: this drug used to prescribe to patients with like different anxiety disorders and all, like different conditions, right? That time People come back, if they were smokers, they stop smoking. That's why they figured out there is some mechanism. Let's talk about the mechanism. Bupropion, nothing to do with the GABA. I don't want you to connect anything. Nothing to do with the serotonin either. This has epinephrine, norepinephrine, dopamine. So the class was NDRI, easy. Norepinephrine, dopamine, receptor, that's a class, right? So in this one, it's actually um, those reuptake inhibitor, right? In the synapse, these two, if you have more dopamine and more norepinephrine in your synapse, you can function well, very good. That is an atypical antidepressant because nothing to do with serotonin. You don't want to worry about that. We are just keeping the other two good neurotransmitters, right? You have norepinephrine enough, dopamine. But this drug also have little affinity to the uh, norepinephrine and dopamine receptors also. Keep in mind, bupropion is a norepinephrine, dopamine reuptake inhibitor, but this drug also has an affinity to, low affinity to those receptors, norepinephrine receptors and also dopamine receptors. Good. Similarly, that is an agonism of receptors, but antagonism of nicotine receptors in the brain. One more point, one more time. Bupropion stimulate or agonize your dopamine and norepinephrine. Oh, you feel good, very good, very good. But antagonizing, blocking your nicotinic receptors, that is the reason you don't feel to smoke. Oh, you don't have any nicotine molecule in the blood. Doesn't matter. You don't even remember about that reason. You already have a lot of dopamine and the norepinephrine stimulator. Hope you understand. I know it's a long, I was supposed to stop at 30 minutes, it went on, but hope you understood that is an entirely different mechanism, and it is used for nicotinic. So because of the antagonism of nicotinic receptors, you can use it for smoking cessation, and Lorazepam is best for alcohol withdrawal symptom. I am going to teach 3 hours next week alcohol drug of abuse lecture, so that time I don't want to discuss this again. So I wanted to study this very well. Hope we covered almost everything. Okay, let's look at some pictures and then we will be done. If somebody asks you why barbiturate is stronger than benzodiazepine, this is it. Both do the same function, both affecting the GABA receptors, helping to open the channel for chloride, rushing in the chloride, but barbiturate, after certain dose, it will keep the chloride channel open forever. That will end up in a lot of chloride channel, so to suppress all this nerve activity, relax and undergo sleep to coma to death if it is certain. That means 1 in 10 patients can die because of barbiturate toxicity. Like, also, this can work without the presence of GABA. That's the term called mimetic action. Gamma barbiturate has GABA mimetic action, but this benzodiazepine is facilitatory action. That is, frequency of opening will be in presence of GABA only benzodiazepine work. In the absence of, after certain dose, even the GABA is not taking part, barbiturate keep the chloride channel open, GABA will be, that's bad. The patient can so, but the number is very low. Like in benzodiazepine overdose, about 1 to 1000. I just put it 10,000 to make it longer, but keep in mind 1 to 10,000 or 1,000 patients can die, but this barbiturate is 1 in 10 patients. That's a lot, right? Anyway, so that's why, keep in mind why it is so much restriction. And last slide, some anxiolytics have delayed action. Okay, in the previous section, what I discussed was all those drugs were fast acting anxiolytics and all those, right? Benzodiazepine fast acting, that's what I was discussing. If somebody asks you why some drugs are slow acting, this is an answer. I remember this way, like I am from Kerala, India. We used to use a lot of copper vessels, right? So if you leave it not cleaning for a long time, it's like a rusting of iron. It's called patina, right? It's going to be like really not like shiny. It's kind of rough. But if you clean it every day for next 1 week, like not 3 weeks, 4 weeks, a month, it will look like clean. Similarly, when you are depressed, your neurons have a lot of like a, it's like a waste, lipid rafts and everything block your normal signaling. That's it. In your neurons in the brain, when you are depressed, it is not, some of the signaling molecules are not working. Your G protein coupled receptors, adenyl cyclase, nothing working. So even if you take the drug, it's like a machine not working. It's like a scissors. You put it in the rain outside, it rusted, it's not working well. If you just use it for continuously, it will similarly. Remember, protein synthesis need time. So when you, after a couple of weeks, you produce new receptors so that the drug can function very well. That is the reason some of the drugs you need to take couple of weeks so that it will start working. That is one of the reasons some of these antidepressants and some of these low acting anxiolytics works delayed. I think I covered more than benzodiazepine. Hope you understood. This is a very super important topic for your clinical practice. Study well. That's it. And yeah.